So a warm welcome to the Kiel Imaging Seminar, everybody. It's great to have you all here today, and I'm very happy to introduce to you our KIS speaker for today, Dr. Graeme Campbell. Dr. Campbell did his PhD in biomedical engineering. He received this PhD from the University of Calgary in Canada, and since then he dedicated his scientific career on the development of CT imaging and computational methods for evaluating bone structure and strength in clinical and preclinical applications. In the same year, in 2011, he moved to Germany to do a postdoctoral position at the Hospital of Kiel, and actually here to the section of biomedical imaging. After 3 years, he then moved on to his second postdoc at the Technical University of Hamburg. It's just about an hour away from here before he eventually started working as a clinical scientist for CT at the internationally renowned company Philips. And there he's still promoting joint research and development with Philips customers across Europe. And so with this, Graeme, the stage is yours.
Okay, thank you. And thanks everyone for joining. I just was showing my team just a little bit of my position at Philips, but I'm excited to talk to you a bit about what we're doing as a company, my involvement with it, and how the role of CT a little bit is changing in the clinic and some of the research and development activities that we have in that direction. So as Ronald mentioned, I'm a clinical scientist in Europe for Philips. So we have a team, we're actually 7 now, there's 6 here, but we're 7, where we're supporting research projects, we're driving research projects, working with our R&D team, but also working with customers that have our scanners. So looking at new developments, supporting research projects, things like that. So it's an exciting position to be in. There's a lot of really interesting and exciting developments in CT. So I'll talk about that a bit here. Our team, we cover kind of any area of CT that there is in principle, but we also do have, some of us have certain specialties. And so we're a little bit in the direction of subject matter experts. For example, for me, I have a lot of background in MSK and trauma, so that's where a lot of my work focuses. And today I'll talk about sort of how all these domains are changing and developing. So I know that not everyone is maybe specializing in CT, so I'll talk a little bit about the role of CT in clinical imaging and where it's beneficial, where other modalities are typically used, where CT is limited, just as a bit of a basis. But then I'll talk about the major developments that we have. So a big one is spectral CT. You may have heard the term dual energy CT as well, so similar idea. So where, you know, this is at the moment and where it's going. Photon counting as well. You could consider this an advancement of spectral CT in one sense, but of course there are fundamental differences, so I'll talk about that. And artificial intelligence, so how we are developing and using new AI methods in the context of CT. So I'll talk about this as well. So I hope you are interested and enjoy. CT is really the workhorse of the radiology department. So why is it used? Mainly because it's fast, it's 3D. Spatial resolution is relatively high. So, okay, if we're talking about a research environment, maybe not so much when we have pixels on the order of 0.5 millimeter, but relatively this is high spatial resolution. And the hard tissue contrast, so bones and calcification is quite high. So if you think about an emergency department where you have a polytrauma case or a stroke or something where time is really critical, a CT is often the first thing done. Despite, of course, there's ionizing radiation or there might be poor soft tissue contrast. In cases like trauma and stroke, the time is the most important thing. But these are still limitations, and this all often results in either follow-up imaging needed, or also missing diagnoses if follow-up imaging isn't done. And of course, radiation is always a concern. So we have to be careful of that, and that plays a role in the decision-making of which modalities are used. So where is CT used? I mentioned sort of the emergency department situation. So somebody comes in with chest pain. You want to know, is there a heart attack, or is there a pulmonary embolism or an aortic dissection or something like this? So we get very nice images of the vasculature of the heart, especially the like the coronaries. Cardiac function might be a little bit different. That's where often MR is done, but really looking at the structure of the vasculature and the perfusion of that is where we're looking. Stroke I mentioned as well. So here again, we're looking at, is there a blockage? We want to see the vasculature. Is there an occlusion in the vessel? We can also do perfusion, where we look at the if there's an infarct, or if there's sort of an area where we can salvage some of the tissue, and this again plays a role in the decision making for the surgery. Trauma, so fractures, of course, seeing is there a fracture in the skeleton, but also in the soft tissue, and of course, oncology, often with staging, whether it's in soft tissues, but also looking at metastases into the bone or bone cancer. Is an important role for CT as well. But often in this case, it's in combination with other modalities. I talked about limitations. So of course, every modality, there are many limitations. In particular with soft tissue, it can be difficult to see differences where contrast is relatively low. So you have an organ and you're looking through the slices, doing the reading, and you're looking to see if there are any lesions, or if you see one, what is it? So you have cases where there's a lot of uncertainty if something is there, and if there is, what is it that I'm looking at? Also with the contrast, timing is very important. So if we're talking about injecting a contrast agent like iodine, to see the vasculature, to see those nice images that I showed, for example, in this case, we're looking at, say, the femoral artery, and we want to know, can I put a catheter through here? Or is it blocked with, calcifications or something? But if we don't have the contrast to see anything, then we can't make the decision, and we have to rescan. You may have heard of limitations like beam hardening in CT. So this is where we have, in what should be a homogeneous material, but we have hypodense or hyperdense regions that clinically would indicate a deficit, so infarct or something like this. But because of the really high iodine concentration in the heart chambers, we can get perfusion, we can get beam hardening. So we don't really know when we see this, is that actually real or is it an artifact? And also, if we see something I mentioned, we see something, but what is it? So if you have a patient with a stroke and you see where the embolism is, and you go in and you get it out, mechanically, say. But by doing this, you have a chance of rupturing the vessel. So when you do a post-op scan, you want to see, do we need to go in again? And you see something like this, and you don't know, is this a bleed? Did we rupture something? Do we need to get back into surgery? Or is this iodine that was just still there from the previous scans? So we can't really tell this. And then I mentioned we can detect fractures really well with CT, skeletal fractures. But if somebody comes in with multiple fractures or any fractures, and we don't know, is that actually old or is it a fresh fracture? Do we need to operate? We can't really tell with CT. And then follow-up imaging like MRI to see, is there edema around it? Is it fresh? Is needed. So basically, this is giving us a lot of uncertainty in many applications of CT. And that's where a lot of the development is going. And that's in particular what I'll talk about is next is spectral CT, where we can address a lot of these. So I won't go really too much into how CT works in detail, but just in case it's somewhat new, essentially what we're measuring is the attenuation of X-rays through the body. So in principle, like an X-ray, but we're doing it in the sense of rotating the beam and the detector around the body so that we can get slices, tomographic slices, and these are stacked together. So that's how we essentially get 3D images. So we're looking at the change in the intensity between the X-ray tube and the detector. So this is measured as attenuation coefficient. So we don't need to worry too much about how this is calculated, but essentially different materials will attenuate differently to different degrees. And this is converted into what's known as a Hounsfield unit. And basically what this means is the actual pixel values that you see in a CT image will have a number associated with it, and that's the Hounsfield unit number. And if it's water, it should be 0. If it's denser or higher atomic number, it will be higher. And if it's fatty, less dense, it'll be lower. So these are values that then you can get an idea for what kind of tissue it might be. This attenuation data is captured as what's known as raw data. So you have this sinogram. This is basically caused from the rotation of the beam and each viewpoint that you have. But this is then reconstructed into what we see as the CT. And there are different ways to reconstruct this, and I'll talk about this later on. But essentially, what we want to get is an image where we have the best signal possible, the least noise possible, and in order to make a diagnosis, and of course, as fast as possible. So Hounsfield unit, I talked about, it's all relative to water, so that's why water is 0. Fat would be less, air even less. But bone and organs will be a little bit higher. You can see already that the individual organs are quite close together, so this already makes it a little bit difficult to distinguish. But essentially, the problem comes when I showed some images when we can't really tell what a material is. So for example, if I would plot the attenuation of the X-ray beam over different energies of that beam. So if you think of a really high energy beam, most of the X-rays are going to pass through, not much will be blocked. But if you have a low energy beam, more will be. So this causes a curve like what you see here, where, for example, with bone, so that would be this line here, is attenuated very highly if we have very low energy, but it goes down with higher energy of the X-ray tube. Same thing with iodine, and pure iodine and pure bone we can distinguish quite well. But if we're injecting iodine as a contrast agent, it's going to be diluted, and it's actually going to be around like this. So we can't really distinguish bone or calcium and iodine very well at all. But if we would measure twice, or we would have 2 pieces of information of this energy or of this curve, then you can see that they're actually unique. So the material type and the energy will have an influence, as well as the density. So there are all these factors that play a role into this attenuation that we're measuring. And so that's what we can use this information. So we know that the energy, okay, we know what energy our beam is from the output, and we're measuring the attenuation. And we want to find out the material type and the density. And because we know that each of these are unique, we can determine this if we have 2 points. And that's where spectral CT or dual energy comes in, because if we can separate the beam into 2 parts, then we can get 2 pieces of information and determine this. So that's where spectral CT comes in. Or as I said, you might have heard the term dual energy CT. So what do we want to do? Well, when the X-ray passes through the body, it's attenuated, so it doesn't reach the detector. That's the main thing. But the reason why it doesn't reach the detector can be a number of things. And in the range of energy for CT, it's either a photoelectric attenuation or it's a scatter. So it's basically absorbed or it's scattered. Now, what will occur is very highly dependent on the material and the energy. So photoelectric effect, this is basically if you're getting to an energy very close to the K edge or the outer edge, that you get to this photoelectric effect happening. You're right at this energy to absorb. So this goes down significantly as you get higher energy. They're either scattered or go through. Compton scatter is very consistent, or constant rather, through the energy spectrum. So you can see already there's a dependence on energy. but there's also a dependence on the material. So water is a very low atomic number. K-edge is very low. And so you'll have mostly Compton scatter. So if water attenuates, it's going to scatter it. The energy is going to be most likely too high for anything else. But iodine, a very high atomic number, you'll have much more likely to have a photoelectric occurrence happening. Calcium is kind of in the middle. So already now you can see if we can distinguish the type of attenuation that's happening with a given attenuation, total attenuation, we can tell what kind of material it is based on the atomic number. And that's exactly what we want to do. We know the energy, we want the material and the density. This is what we can determine. So how do we do this? Our technology, so there are a number of technologies, I'll touch on this in a bit, but our technology is called dual layer CT. So we have in the detector, we have an upper and a lower layer. The upper layer, and so they're different materials, and the upper layer will absorb the lower energy photons, and the lower layer will absorb the higher energy photons. So the higher ones pass further through. So we get two synchronized raw data sets, and these can be decomposed. We have a decomposition algorithm that will decompose them into the photoelectric and Compton scatter. So we're from this, by splitting the beam into the two energy spectra, we can now determine the photoelectric and Compton scatter attenuations. And we have the raw data, but we can also reconstruct if we wanted to images. Now these images on their own aren't diagnostic, but if we would plot every pixel in the photoelectric and the Compton scatter image against each other, so we take from this image, for example, we get something like this. So say we have a pixel somewhere in the aorta. So the aorta is going to be blood and iodine. It's going to land somewhere here. If we have it in the bone, it's going to land somewhere here. And you see these vectors, which are indicating the different types of materials. So water and iodine, or blood and iodine, will be somewhere here, bone somewhere here, fat somewhere here. And how far along these lines you are tells you the density. So now we have the type of material and the density from this information. And this is how we get what we call material images. So we can produce an iodine image where instead of a Hounsfield unit, we can tell you the concentration of iodine in that pixel. We can also remove, for example, a virtual non-contrast. So instead of scanning twice with and without iodine, we can just virtually remove it, knowing this. Uric acid, so in the case of gout or kidney stones, this is important for diagnostic decisions. And calcium suppression is basically removing the bone so that you can see essentially changes in the bone marrow. So these are examples of material images that we have. If we would combine the photo and Compton images with different weighting, you remember I showed how the energy effect of those two attenuations, so photoelectric much higher at low energies versus Compton. That's basically combining these will give what we call virtual monoenergetic images. And these are showing what the image would look like if you would have a monochromatic X-ray. So our X-ray is a spectrum, the X-ray beam. But if you would have only 70 kilo electron volts photons, for example, or only 40 or only 200, then you can generate these. And you can see already that the contrast changes. So much higher contrast in the lower energy images versus in the higher. But we find we have fewer artifacts in the higher. So this gives us more options for depending on the clinical case. So I kind of touched on this already, but we have the material images, also electron density. This is essentially a density of the image, independent of the material, independent of the atomic number. So how dense is it? Z effective is the average atomic number. So regardless of the density, what is the atomic number in that pixel? And it's an average in the pixel. And then these are already touched on. So uric acid, calcium suppression, iodine, and virtual non-contrast. The mono-E's, or I call the mono-E's, the mono-energetic images, will give, as I showed, difference in contrast because contrast and attenuation is dependent on energy. So if we would move up to a very high energy photon beam, monoenergetic, we would have very little attenuation and therefore little contrast. but we actually can reduce the artifacts or the bloomings and things like this. On the other hand, we go down to a very low energy beam, simulated beam, and we can see much better contrast, especially if there's iodine or any sort of high atomic number material. But even within soft tissues, we can start to distinguish better. And an example is, for example, like if we have in the liver, we have a lesion very difficult to see in a conventional image, or this is actually a 70 kiloelectron volt image. Very difficult to see. If you know it's there, you see it, but if you're looking quickly through it, very easily missed. You can go down to a lower energy image, and it's quite apparent that it's there. And it's also easier to delineate. And the important thing too is we're able to keep the noise in these images very consistent. So that means that the contrast to noise ratio gets higher when we move down in energy. On the other hand, if we go the other way, so I mentioned artifact reduction. So this is something, of course, metal artifacts are a big problem in CT. If we have orthopedic hardware or, valves of the heart or things like this, and it's very difficult to make any sort of assessment of placement or things like that. So if we move up to a high energy image, we can really greatly reduce the artifacts that we see. So going back to what I showed before with some of these limitations, so conventional image Hounsfield units don't really see anything, easily missed. As soon as we go to a low energy image, this is the 40 kiloelectron volt image, we all of a sudden see a lesion where we really didn't see it before, or would have been very difficult to see. We can also use an iodine map. So now this is actually showing, it's kind of cut off, but the iodine density in milligrams per mil. So again, we can see the lesion very well, and we can assess it according to how much iodine uptake. Same image, conventional versus a monoenergetic, so a low energy image. Now we can very easily see the structure of the vessels and any sort of stenosis or things like this. It turns out this was a perfusion deficit, because when we go to an iodine image, so now a spectral image, we could do this with the mono E as well, we see that the iodine density is actually homogeneous and there's no perfusion deficit. Here we wanted to know, is there a bleed or is it contrast agent? Well, if we look at the Hounsfield unit here, and it's very difficult to see, and I apologize, but that's 65, Hounsfield unit of 65, but the non-contrast, virtual non-contrast is 30, meaning this has contrast in it, because if we remove it, we see a lower Hounsfield unit. So, and we also can confirm that with the actual iodine image, which is showing over 1 milligram per mil iodine. So now we know this is contrast agent. It's not a bleed, so we don't need to worry. And here we see a fracture, but is it acute? Do we need to operate? And in this case here, yes, we are seeing in the calcium suppression, we're removing the bone, and now we can see the soft tissue much better. And we can see a very hyperdense region, and this would be the edema. So this means it's a acute fracture. You can also see, for example, the discs a lot better, and that's something where we're also looking into a little bit. Can we get better assessment of the joint, the surrounding joint tissues and morphology and things like that? So we see a lot of added value clinically. For example, I showed earlier with the lesion with the iodine uptake, and again here another example where this would be a lesion that is which is hypodense, so it's not, so we have a cancer that's not taking up iodine, and we don't really see this contrast in the conventional image. Remember, CT soft tissue contrast is relatively poor compared to MRI, for example. But if we can increase the contrast by reducing the energy, then we see the iodine uptake much better, and we can see areas where there's no or very little iodine uptake. And it can be overlaid to keep the anatomy if that's preferred. And same thing here. This is a case where if you knew it was there, you probably would see a difference in contrast, but this is very easily missed. And again, with the low energy images or the iodine. So we're able to really increase the certainty and reduce follow-up imaging or rescans or things like this. With occlusions, where I showed we were talking about, for example, in the brain, but now here in the lungs, an embolism. So we're looking for where do we stop seeing the signal from the vessel, really? And you can scroll through and you can try to find it, which is what's done. But if we apply, for example, an iodine map or even sort of the average atomic number, because the lungs are taking in, the lungs are highly vascularized, so taking up a lot of iodine. But in regions where there's an occlusion and they're not taking anything up anymore, this goes dark. Or in the atomic number, we see a large change. So this you see immediately. You don't really have to even look closely, so it's much easier to catch. And again, with the myocardium, CTA, so computed tomography angiography, so the CTA, is becoming the standard for looking at the coronaries, so looking at the morphology, the stenosis of the coronaries, but really looking at myocardial function is not really done. But if we can see better the perfusion deficit, so where iodine again is not being taken up, we can much better assess the function, so the result of any sort of stenosis or blockage. So that's something we can see here. Going to MSK, which is sort of, as I mentioned, a little bit more my focus. I showed the example of the bone marrow edema. So that's just another example here where we see with the calcium suppression, we can see much better where there's an edema. So we know, okay, this is a fresh fracture. But as I said, we can also see the discs a little bit better. So if there's a herniation or something, it might not be that you would do a CT just for that purpose, unless you really didn't have an MRI or was completely blocked or things like this. But if you have the CT because there's a trauma or there's, for whatever reason, then the information is there and you can use it and you can avoid the follow-up scanning. And again, here, this is interesting to see the cartilage. So something that really you would never try to do with CT without any sort of contrast agent. But here with the calcium suppression, removing the bone, we can get a better contrast in the cartilage and the surrounding tissue, especially at the bone cartilage interface. So we can see areas where there's degeneration or possibly injuries, changes in morphology. So this is really experimental and sort of in a proof of concept phase. This is published independently from us anyways, but it's really interesting to see and to look at the potential. So we're kind of exploring when would this be used, would it be used, and how can we sort of move forward in this direction. Yeah, and I'd already talked about this, so I think this is just an example of the bleed versus the residual iodine. In this case, if we remove the iodine signal, so we've now made a virtual non-contrast, the signal is still there. So in this case, it is a bleed. So then something definitely needs to be done. But also looking at not just focusing on iodine, but other materials, other tissues. So this is an example where there's a gallstone in the bile duct, and you just really don't see anything in the conventional image. But looking at the average atomic number, a lot of times it doesn't even have to be quantitative. You just look for changes in signal where there shouldn't be, and you can identify where something is going on. And in this case, the color map is a bit confusing, but the red is a low atomic number. So cholesterol stones would be a lower number compared to the surrounding tissue, and that's why you see them in red. I talked about this already. So we have various ways to reduce metal artifacts. One is OMAR. It's our sort of iterative method to reduce artifacts, nothing to do with spectral CT, so orthopedic metal artifact reduction. But combining it with a high energy spectral image, we can really, if you look compared to the original, how well the artifacts can be reduced. So this makes it possible to really assess more the placement of the screws or whatever hardware might be there. Just another example, just in 3D. And also, I touched on beam hardening, and this is a problem in really any patient. It's a problem to some degree, but obese patients, very large patients, it's very difficult to make diagnostic images when you have very large patients. So by with spectral CT using the spectral images, we're able to reduce the beam hardening because we're essentially, through the material decomposition, we can apply a material-specific beam hardening correction. And this allows us to get much higher quality images with fewer beam hardening artifacts. And this I showed already, so I don't need to touch on that as well. And moving on, so that is all. Some of that is a bit more research, but a lot of it is really just how it's being used clinically. Where we are doing a lot of research and looking at potential is newer spectral maps or new applications, things like that. And I talked about an iodine map, which is basically an iodine water model, or a calcium water model, which is the calcium suppression. But we can really, any material or any pixel that contains 2 or up to 3 materials can use a material decomposition to calculate the respective volume fractions. So we know that the attenuation is made up, for example, if we have 3 materials, it's the component, the volume fraction, and material attenuation coefficient of each of the individual materials. So add them all up and you get the total attenuation. But we have 2 energies, so we can distinguish between up to 2 materials. But if we make the assumption that the volume fractions add up to 1, which isn't necessarily true, but depending on the situation, if we make this assumption, then we have 3 equations, and this becomes essentially we're inverting a matrix to solve the unknown volume fractions. So the F, A, B, and C are the volume fractions, and we can essentially solve it. So if you remember the plot I showed, I talked about photoelectric and Compton scatter, but we can look at other base images. So for example, the atomic number and density, or the low and high mono energetic images. And we can essentially define 3 materials, and we can calculate the respective volume fractions. And so that's something we're doing right now. This is an example of a study we're doing at Hamburg at UKE, where we're looking at fat in the liver, but also in the context of iodine. So these are patients that have contrast-enhanced scans. So looking at the Hounsfield unit to try to see fat content is impossible because you have iodine uptake. So looking at how we can use spectral to calculate fat fraction. So to look at steatosis or something like this. But not just in the liver, also looking in the muscle. So this would be more in the context of sarcopenia, again with iodine. So these are contrast-enhanced scans. I talked about edema with the calcium suppression, but one could also go a step further and really decompose into the sort of the yellow and red marrow, or water-like and fat-like marrow and bone to get a better model. And of course, if you're looking at bone marrow, you can look at bone mineral. So looking at a bone mineral density. And this is interesting because typically for bone mineral density, you would do a QCT if you're looking at CT, a QCT. So looking at a phantom calibrated CT scan or PMD score. And that limits the patients that you can assess, because the vast majority of patients aren't scanned with a BMD phantom. So if you can do this with other methods that don't require phantom, now you can look at opportunistic screening or things like this. This is an example where this was actually at Kiel, so at the UKSH in Kiel. And we looked at the electron density as a measure of essentially a hematoma. So when you have a bleed and it's coagulating and it's basically becoming denser. And this is what happens, of course, around the injury, the fracture. And so this is known as, in this case, a prevertebral hematoma. And this gives a lot of information in terms of, is there an injury and where and how stable? Often you don't see the fracture. And so this was a study where we looked at electron density compared to the conventional images and compared to MRI. And we saw a really added value in terms of diagnostic accuracy of the electron density images to detect the hematoma versus conventional, and using MRI as a gold standard. So this is a case where normally you'd have to have both, and often an MRI isn't done. If we think, okay, there's no fracture, no need, and that can be definitely dangerous. So if you have this information already, then you can avoid that. And then also looking at more diagnostic capabilities in terms of iodine uptake, in this case in the adrenals, as a risk factor or things like this. So it's a lot of where we're going in the spectral results that we have is looking at, okay, we know what they do and the images look nicer, but how does it really affect clinical routine, clinical decision making, and added value in that sense. So these I showed already as far as the fat mapping, but also looking more into the joint. So I showed one with the vertebral disc, but also potentially looking at ligaments or tendons. Are there injuries or degeneration? How well can we see it? That's kind of a big question mark. So something that we're looking at. BMD I talked about. Also in the context of edema or ischemia in the brain. So this is actually work we did in Kiel as well, where we want to see can we, in a non-contrast, the very first scan that you do of a patient with a suspected stroke, can we see already the ischemia, which is basically the cells dying, in as soon as possible, because in stroke the term is time is brain. The longer it takes, the more brain damage occurs. So the fastest that you can detect something and make a decision, the better. And I talked about edema in the bone marrow, but also looking at fat fraction. So in the context of multiple myeloma, or also in terms of inflammation or things like that, where typically in an MRI, you're looking for an increase in the water signal. Can we get that from CT as well? So photon counting CT, I'm just looking at the time, so I'm going to go through this a bit more quickly just so we can get to everything and have time for questions. But photon counting CT, maybe you've heard of as well. It's a different technology from the detector side, but in a lot of ways is similar to spectral. So conventional detector, single detector measuring the basically summing the attenuation. Dual layer I talked about, so we essentially are dividing the spectrum into two parts, a high and a low energy. You can do this with two tubes as well, and that's why I say dual energy is typically referring to a technology where you have two tubes instead of splitting at the detector, so is an alternative. Photon counting is quite different in the sense of the detector is different. So we're able to get multiple bins of energy. So divide the beam into multiple bins, basically. But this is done using a semiconductor, which is really measuring the energy of every single photon and putting it into a bin. And so why is that important? Well, currently, what we see a lot of is high spatial resolution, because you can really reduce the noise, but you also, because of the nature of the detector, you don't have basically you can put the pixels a lot closer together without any or without as much cross scatter, but I'll get to that in a second because there is still some, but essentially a lot higher resolution. So we're talking about up to say 40 line pairs per centimeter, but that's really the maximum. So it's not necessarily clinically that being used. But these are just some examples. We have a prototype scanner in France where we've looked into this in a lot of different areas. So cardiac imaging with a stent and calcifications, or bone, looking at the bone structure in the inner ear, or in sort of looking at the spongiosa, or even potentially with cartilage. So a lot of potential. How it works, essentially, as I said, it's a semiconductor. So when the X-ray hits, you have an electron hole pair forming, and you essentially have the anode and the cathode. So basically, positive charges one way, negative the other. And this is dependent, so the voltage that you measure is dependent on the energy of the photon. So essentially, you measure the energy and put it in a bin. And you can set the range of those bins according to the question you have. The nice thing is you can, first of all, have a number of bins. You can set a threshold of the lowest bin to eliminate a lot of the noise. Caveat is this is the background noise. As soon as you have signal, then the noise is also up here too. So it's not like you're completely removing the noise, but it certainly is a lot less. And this is what I meant with the detector, that the pixels are a lot closer together. So that's part of the, between reducing noise and having smaller pixels, you can get higher spatial resolution. A big advantage, or I would say potential, because it can't really be used yet, is K-edge imaging. Currently, iodine is really the only approved contrast agent that's used clinically, and the K-edge for iodine is quite low. So K-edge is this blip that you see in the attenuation. Maybe you saw it in the image that I showed before, where you have a reduction in attenuation with higher energy until you get to that K-edge, so the outer shell, where all of a sudden now the photoelectric effect is happening and you have this boost. And if you imagine you have bins of energy, so you're basically setting bins of energy right above and right below, then you can basically subtract those and only this material will show up because everything else is subtracted. So if you do that, then you can get things like a water image or a gadolinium image or a gold image or things like this. But iodine is just too low, so you would have to do a standard material decomposition to get iodine, but you can do it. Great idea, and we're working a lot on this moving forward, but there are a lot of issues currently with all systems, like even clinically available systems, things like if you have smaller pixels in your detector, you have a higher chance that you're going to share the charge. So the charge is going to basically split between the two and you have signal in both. Or if the pixels are too big, you might have multiple charges hitting at once, or you have charges that, they're measured here, but the photon doesn't completely leave. Things like this. So there are a lot of things to address, but it's a very exciting technology. So I showed high resolution. So just to move on with the time. Reducing the number of scans. So typically, if you want a non-contrast scan and then multiple phase, so for example, the arterial phase and venous phase to look at uptake and things like this to characterize a lesion or what it might be, you have 3 scans, one without contrast agent, you inject contrast agent, and then 2 more scans. But if you can do K-edge imaging and you can do up to, say, 3 materials, you can inject once, you can inject twice, so 2 different materials, you scan once, and because these are timed differently at the arterial and venous phase, now I can just split those materials and identify which they are, and one is the arterial and one is the venous, and I can also remove them to get the non-contrast. So this is really able to reduce the radiation dose a lot. And this is just an example, I think this was in rabbits, with gadolinium and iodine. So basically 1 scan, but now we can get an arterial image, a venous image, and also a non-contrast. It isn't shown here, but we can do that as well. You can also use nanoparticles. For example, this is a study looking at nanoparticles, gold nanoparticles, and then looking at the K-edge of gold to see the macrophages and the plaque. They bind to the macrophages, and you can really get a good assessment of the plaque and the lumen here. So the blood vessel here is seen very nicely with the iodine, and you can combine these as well. And then the last thing I want to talk about is artificial intelligence. We're doing a lot in this area. For example, image reconstruction is one that is a big focus at the moment, and this is, of course, has in the context of image quality. So I won't go into too much detail here. There are a number of different methods. Filtered back projection is sort of the first and most basic and also least computer intensive method, but has a lower image quality, of course. There are different iterative methods. I won't go into detail here, but one thing I just wanted to mention is depending on the method, you can reduce. So we have what's called a hybrid iterative method, which is basically kind of you do the iteration separately in the raw and the image space versus the model-based, which is kind of continuous back and forth. You can really drastically reduce the noise going to each of these, especially into the model-based. This is actually a neonatal scan, very, very low dose. That's why you might say the image quality is terrible, but it's actually very, very low dose. So, but what you can see is a lesion that is almost impossible to see in the other methods you could see with the model-based iterative. But what you might notice is the texture of the image is a little bit plasticky, and that's what a lot of radiologists complain about and say, well, I don't really trust it or I don't like using it. And if you look into detail at what's known as the noise power spectrum, and that's basically the texture. So what frequencies does the noise have and where sort of are they mostly? And if you imagine a normal noise spectrum that's like this, the filtered back projection, but if the frequency of the noise shifts to a lower frequency, that's what gives this sort of plasticky look. And that's what we see with this method. So we're working on, and this is actually released now for on our conventional scanners that we use AI based. So this is trained on basically normal dose data, but then simulated low dose, and we train it so that it's producing normal dose data, but at a lower dose. So basically, where it's basically a noise reduction algorithm that's trained on standard dose. And what we find is that if you look now at the noise power spectrum, this is in phantom data first, that you have a reduction in the noise altogether. So would be the filter back projection, and then this is our hybrid iterative here. But then these colored ones are the deep learning or the AI method, and we have a lot lower noise with these. But also, if you look at the peak of this curve, it's the same as the filtered back projection. So the feel and the texture of the noise is very similar. And we see that we call it, so the product name is Precise Image, and iDose is the hybrid iterative. So this is the AI on the right is always the AI, and on the left is the iterative. And you can see definitely qualitatively as well a reduction in noise, but the texture isn't patchy and different. It's a similar feel, just that the noise is lower. And this is really the goal of what we wanted to achieve. And so we see this really in all areas. And so now a lot of what we're doing is, okay, where do we see the added value? Where is it working? But also, okay, this is conventional, but what about spectral images and other types of images? So working on this a lot. Just in the context of time, I think I'm gonna just quickly just show, but not really go into detail, cardiac motion we're also looking at. So, or we have looked at, so this is actually a product as well, but detecting the type of motion, and it's basically the direction of the motion in the coronary. So this is the coronary artery that the whole point of doing the scan is to see if there's stenosis, if there's narrowing, and you can't do that here. So looking at the motion and correcting for the motion. So that's another topic. I won't go into detail unless there are questions, then happy to discuss more. But we're testing this now clinically. And then the last thing is, this is still very much research, but automated detection. So based on, annotated data, so ground truth data, training a deep learning model to detect certain lesions or certain anatomical parts. So in this case, the lymph nodes. So is it detecting the lymph nodes? How many? Is it counting? Is it doing volume? Things like that. And this was with Kiel, looking at fractures, but not just detecting if there's a fracture, but also if it's stable or unstable, segmenting the anatomy, things like this. So and we're seeing really nice results that we're able to detect fractured versus not, or stable versus unstable. So that's what I wanted to discuss. Sorry, it's got a bit fast at the end, but of course, if there are questions, or I can discuss more about some of the other topics. But yeah, I hope you kind of got a bit of an overview clinically how CT is used, what it's really good at, where the limitations are, and why we want to work, at overcoming those, mainly through developments like spectral CT. So how do we use spectral CT to reduce dose or to improve contrast and improve diagnosis in the end? Photon counting CT, this is a really exciting technology. It's very early, so currently clinically it's quite limited, but there's a lot of potential, and artificial intelligence. So in particular, where we're focusing a lot is image quality, but as I mentioned, reducing rescan. So I touched very briefly on the motion, but also detection and workflow, because one thing that radiologists are constantly telling us is we don't have time. We're overworked. There are too many images, too many readings, because there are more and more CT scans performed every year. It's going up. So anything that we can do to improve workflow with automation, things like this are helping. So yeah, so that's what I had. I hope you enjoyed. And if there are any questions, I guess we have probably a little over 10 minutes. So feel free to ask.
Thank you very much. Very nice. Very nice. I really enjoyed it. And I made a lot of notes, but I'm actually very happy that we are recording this. And so I definitely look into it again. We have a couple of questions in the chat, and I see that Niklas also raised his hand. Niklas, do you want to go first?
Yeah, wait. For me, it's very interesting. So there are also some CTs with a very high radiation dose, and in comparison to spectral CT and photon counting CTs, um, oh, here, how can I say this? Um, Maybe in German. Sorry for that. Also, wenn ich jetzt ein Extrem-CT mit einer hohen Strahlung habe und daneben ein Photon-Counting-CT lege oder ein Spektral-CT, habe ich da, also kann ich theoretisch über so ein ganz, ganz fein hoch aufgelöstes CT, habe ich dadurch auch die Vorteile von einem Spektral-CT oder Photon-Counting-CT, dass ich darüber auch zum Beispiel die Material-Specific Images zum Beispiel hier für den Soft-Tissue-Contrast dort angeben kann? Oder ist es wirklich entsprechend dann für diese Technik, also ja, vielleicht, sorry for that.
No, it's okay.
It's a very complicated question. So
do you mean so you mentioned the extreme CT. So are you talking about micro CT and a high resolution CT? Can you get similar information?
yeah, right.
Material
Yeah,
properties?
that's it.
Yeah, so those are two different things, and that's where photon counting can be a bit confusing because to get the properties of the material, you have to have those basically two data points. So you have to have two different energy spectra, however you get it, whether it's detector based or photon counting where you're binning it or things like this. So having a higher resolution only, like an extreme CT, will and if yeah, depending on radiation, so you'll reduce noise with high radiation, but you'll get a high resolution, but you're still working with Hounsfield units. And
Right.
specifically Hounsfield units, you can't distinguish between atomic number and density. The only way to do that is to have two informations on the attenuation. So, and it goes back to the, if I, let's see where it might have been, the energy curves. If I, oh, sorry, I just have to skip. If I go back to this point where I can't distinguish between bone and iodine, even if I had really high resolution, unless I know something about this profile of the energy attenuation. That's the only way you can do it.
Okay. Thanks.
Very nice. I mean, this is sort of, for me, it's going into super resolution. That's for me a keyword, noise reduction, that you showed. Is there also a plan to do that kind of thing for implant scans? That you mentioned with high energies, you could actually visualize a bone and implants very well, and you showed images, great images, by the way. And then is there maybe also a project where you try to get this information, get nice images from a patient with implants, but actually having them scanned with low energy? Because that's for me, it's, as I understood what you said, it's the same thing, right? You could train a model on high energy scans and do the same scan with low energy and then train the model. Is that possible? Did you look into that direction, or is that
Yeah, so I think that's, yeah, so we're definitely looking into that direction. As far as training on a high versus a low energy, I don't know if that's really being looked at, but we're certainly looking at AI-based methods. So training with and without an implant, it would be simulated if it's clinical data, but of course with Phantom, you can take it out or not. So there's definitely work on an AI-based metal artifact reduction. With the high and the low energy, I think that is interesting because then you can you would train it on the high, but then you have to still maintain the contrast. And as soon as you go to a lower energy, you would have better contrast, but you would have the artifact. So I think that's where the challenge would be. But I think, yeah, it's a good idea, and it's something that if you can find a way to yeah, because you would need to remove the artifacts but still maintain the contrast. That's really the challenge. But I think there's definitely interesting work.
Yeah, we should stay in touch. Before I actually read a question that would be from the chat that is going along the lines, Professor Hövener raised his hand. Please, Jan.
Yes, thank you, Graeme. Very nice talk, and I finally have some questions in my head resolved about energy and photon counting. Maybe I can ask you to go back to the slide where you showed the 2D plot of photon effect and Compton effect.
Yes, I think that was.
I think it was to the left, like more to the beginning, but you talk better.
This one here, or?
No, the 2D plot where on the Y scale you had the photon, and then the X scale you had the Compton effect.
This one?
And then you had the different, yes, this one, exactly. So for what energy is this?
Oh, so yeah, I didn't.
For the whole spectrum?
So probably this particular scan, like this actual data was probably done on a 120 kilovolt peak scan. But in the end,
that's like it's the full X-ray spectrum, right?
Yeah, so
that is hitting the subject.
Actually, I had an image. Yeah, it's not here, unfortunately. I had a slide that could have showed this better. But if you imagine this is your spectrum here, can you see my mouse?
Right. Yeah, I see it.
So this is your spectrum here. So this would be at probably 120, but we find the higher you have the peak energy, of course, the better the spectral separation. So we have 100 to 140 where we can get spectral data. Below that, we don't do spectral data because you just don't have the separation. So this plot you can generate with anywhere between scans with 100 to 100, 120, and 140 kilovolt peak. Then you can get this type of data from it. But it's
my question was sort of, why does bone, for example, have such a wide spread? And the answer to that is because it's not monoenergetic radiation, right? Because it's the more or less continuous spectrum.
Yeah. So right. I agree. So you have, of course, the bone is not homogeneous, so that of course plays a bit of a role. But in terms of the material itself, I think it's a combination of you have some sort of beam hardening around it, or you have other materials that would be close to it. So that's where it's bone is the most difficult, or the bone and the marrow are the most difficult to do material decomposition.
Yeah, I don't care so much about this specific tissue. I was just wondering why is it so spread wide, right? Why is it so long? And what is the color code here in this image, and what are the units?
Yeah, so one thing back to your question, and this is something I don't actually know for sure because I don't know what image this was taken from, but my guess is this was a contrast enhanced image. If so, then the pixels that are in the bone marrow environment will have contrast uptake and will be shifted depending on how much contrast they have away from the line. So what I would like to do, and that's interesting you asked the question, because what we should do actually is compare this in a contrast and a non-contrast scan and see what happens here if it gets narrow, because that's my feeling is probably what's happening. But sorry, the units. This is basically, I think it might be just the number of pixels. Like it's basically a pixel density, so how many pixels you have in which spot, but I'm actually not entirely sure. But you can imagine it like a 3D plot, like the more yellow has more pixels in this.
Yeah. I was just wondering about the sort of the physical units as well. Is it like Compton scatter percentage? Like I know that one point has X% Compton and X% photo effect, right?
Yeah. We have units that aren't actually really units. There's some sort of conversion that that we don't really have access to. So I can't actually say what exactly the units are that we have. But the way we do, at least if we're doing for research purposes anyways, the material decomposition, it's really about the relative differences in
Nice.
scatter. So, but I'm not exactly sure the actual units.
Yeah. Maybe I can have a short question, or maybe a little bit longer question too. You spoke about the binning of the photo counting. How large are those bins? And of course, that affects as well your
Yeah,
many things, right?
So we have in our prototype scanner, and let's switch ahead here. In our prototype scanner in France, we are able to get 5 bins.
Yeah.
So, but it depends on the technology and the manufacturer. So we do 5. The lowest one would be sort of here to remove noise, and then you would want to have, for your K edge, you need 2 specific to the K edge. But then if you're doing iodine or material decomposition, you'd need more. So, but we have 5 bins.
Do you know if that's using the Medipix sensor or not?
Good question. I'm not quite sure. I don't know. Yeah.
I just know that the Medipix, I think it was developed for CERN and it's used for photon counting, but I'm not sure either.
Yeah, that could be. That's a good question. I'm not quite sure the details of that.
Thank you. And one last question related to the super resolution and so on. You showed nicely that you take high resolution data or you take high energy data, you downsample it basically to low energy data and that you use for training because you have the perfect ground truth. Can you do similar things for super resolution? Like you take super resolution data, or not super resolution, just very highly scenograms that are very finely spaced, and you just throw away a few lines, or you make the sampling coarser, and train on that. You know what I mean?
That is a very good idea. And that could very well be something we're working on, but I shouldn't talk too much about. But yes, you can absolutely do that.
Okay. Nicholas, you're here?
We can talk.
We can
talk later.
Okay.
I'm
thank
here,
you so
yes.
much. Fantastic talk. Yeah.
Thank you.
All right. There is a question in the chat that was written to me directly. Is there any program to cooperate or contribute to Philips reconstructions? So there is a background is that there is a Siemens corporation to develop MRT sequences with universities. Does Philips has something similar?
Yeah, so we have different ways for collaboration. The projects I'm involved in, we basically sit down and discuss, come up with a project plan, what is needed from Philips' side, what's needed from the site. And then we go from there in terms of getting a contract in place to run it. In terms specific to reconstruction, I'm not involved in a lot of projects that are on the development of construction, but our main part of the R&D team that works a lot with this is in Hamburg, so our Hamburg research team. So certainly, if you reach out to me, my contact information might be somewhere on the post, but you can reach out to me and I can put you in touch with somebody if you think there's an opportunity. Yeah, there are definitely ways to collaborate.
Okay, I think Timo, you heard this. It's not far away. The second question is, do you see market for spectral CT in parallel to photon counting regarding price and availability? And is there a future additional potential for CT imaging such as phase contrast CTC?
Yeah, 2 really good questions. So yes, we absolutely see a market for spectral in parallel with photon counting. A lot of it is because of the maturity of photon counting right now. Current clinically available photon counting scanners are not able to do, or they are able to do spectral imaging, but they're limited as far as the resolution or the field of view or the the width of the detector and things like this. So often you have to make a choice. Do you want high resolution or spectral, and things like that. So I think if with spectral, we have a lot of the benefits in a full sort of clinical scanner. The one drawback is not to have the ultra high resolution. But in cases of, is it a fracture? Maybe you don't see the fracture. Maybe you wouldn't have seen it on photon counting, but you see the edema with spectral. So there's a case where spectral would be desired more, maybe. But as photon counting develops more and more, I think it could certainly take over a larger role of spectral, but spectral is still available as maybe a lower price point option. Phase contrast, dark field, things like this, really, really interesting, and we're involved in a lot of this work. Right now, we see a lot of potential in anything with a change in the microstructure, so lung is a huge thing, and maybe bone. Getting it from those sort of niche areas to a more fully clinical application is the challenge. So is it only useful for those specific questions, and then does the price make sense to buy? Or are there other opportunities? So that's something that I think needs to be resolved.
Right. Okay. So I'd say thank you very much, Dr. Campbell, Graeme, for this great talk. It was well balanced with beautiful images and theory. Thanks to the audience for coming in tonight. And you can so we recorded this meeting. You can watch it on YouTube. I'll put it on the YouTube channel. And thanks everybody for coming. Thank you again, Graeme, for this great talk. And I hope to see you next time at the Kiel Imaging Seminar.
Thanks, everyone.